You're listening to Who Said, a Cardiology Board Review series. No fluff, just facts.
This episode is about idiopathic HCM and HOCM, diagnosis and imaging. We'll go over the epidemiology, physical exam findings, imaging features of hypertrophy, and imaging features of obstruction. We'll delve into systolic anterior motion, or SAM, other imaging findings, and end with catheter-based invasive findings of HOCM. Starting off with epidemiology. The prevalence of hypertrophic cardiomyopathy, or HCM, is 1 in 500 to 1 in 200. HCM has a rate of sudden cardiac death of 1% per year. The overall prognosis is still good, though. 5% of HCM patients have a normal ECG, so you can't exclude HCM just because an ECG is normal. 100% of HCM patients have diastolic dysfunction because a thick wall tends to be stiffer than a thin wall. 70% of HCM patients have SAM, or systolic anterior motion. HOCM is a subset of HCM where the thickened heart muscle causes outflow tract obstruction in the left ventricle, particularly during systole. The obstruction is often dynamic, exacerbated by certain conditions like dehydration and exercise. In other words, the term HOCM involves obstruction, while the term HCM may or may not involve obstruction. Moving on to physical exam findings. Significant obstruction is a peak gradient of more than 30 millimeters of mercury at rest. A peak gradient of more than 40 to 50 is required to result in symptoms, usually. Short of that, it is hard to blame the gradient for causing shortness of breath. The degree of obstruction in HOCM, and therefore the intensity of the murmur, is dependent on preload. When preload is decreased, as with the Valsalva maneuver, there's less volume flowing through the narrowed outflow tract, and therefore more obstruction from increased contact between the anterior mitral leaflet and the interventricular septum, leading to an increase in murmur intensity. Whereas aortic stenosis' murmur decreases when you decrease preload by the Valsalva maneuver. Both aortic stenosis and HOCM murmurs will decrease with hand grip, thus increase afterload. Unless there is LV dysfunction, atrial fibrillation, or primary causes of severe MR, most patients with idiopathic HCM do not actually develop clinical signs of CHF. Imaging features of hypertrophy. In HCM, the ratio of septal wall thickness, or SWT, to posterior wall thickness, or PWT, should be more than 1.3. Older HCM patients typically have localized proximal hypertrophy, also referred to as the septal bulge. The LV cavity shape and septal curvature are normal. The younger form of HCM, the one with the crescent moon-shaped LV, also has RV hypertrophy. The older form of HCM, the one with the localized proximal hypertrophy, does not have RV hypertrophy. HCM will have a predominantly septal reduction in global longitudinal strain, meaning the septal segments will be much less negative than the lateral segments. On histology, HCM will have myocyte disarray. Next, imaging features of obstruction. Although the main shape of the CW Doppler in HOCM is a downward saber tooth, also referred to as a downward dagger, it can also have a lobster claw pattern, which is when there's a mid-systolic dip in velocity, such that the downward dagger has a W shape. There's an initial high velocity followed by a mid-systolic drop in velocity during SAM septal contact when the aortic afterload exceeds the LV contractility. Lobster claw pattern indicates the LVOT obstruction has peak gradients exceeding 60 millimeters of mercury. When performing CW Doppler of the LV outflow tract in A5C for HCM patients, you must take care to avoid contamination with the mitral regurgitation signal, which is present in most patients with HCM due to systolic anterior movement of the mitral valve. When presented with a CW image, you must be able to distinguish if there's contamination. The CW signal of MR typically starts earlier and ends later in systole. MR also has a higher velocity throughout ejection and a higher peak velocity. The CW signal of a dynamic LVOT obstruction has a low velocity in early systole, with a peak near end systole. In a patient with HCM, if the Valsalva maneuver and amyl nitrate inhalation do not provoke LVOT obstruction, you should do exercise echo to see if a significant LVOT gradient develops at peak stress, so you know if you're dealing with HOCM or HCM without obstruction. In contrast to exercise stress testing, which can provide data about risk of sudden cardiac death in HCM and blood pressure response to exercise, dobutamine stress testing offers no additional information in patients with HCM. Additionally, dobutamine would worsen the LVO2 gradient, which would be dangerous. The sequence of systolic events in HOCM leading to MR is eject, leading to obstruct, leading to leak. MR in HOCM is typically eccentric and posteriorly directed. If you happen to see an anteriorly directed jet of MR in a HOCM patient, then you should suspect a superimposed organic mitral valve pathology, most likely flail posterior leaflet. What does it signify in CW Doppler if an HCM patient has an additional downward envelope during diastole, in addition to the expected spade-shaped downward envelope during systole? The timing of this additional envelope is after aortic valve closure during the isovolemic relaxation period, extending into the early diastolic filling period. This suggests the presence of an apical systolic outpouching or aneurysmal cavity. This phenomenon can only occur if there is cavity obliteration. The suction effect occurs from the relaxation of a hyperdynamic midventricle and acts on blood entrapped within the stretched apical cavity during systole due to apical asynergy and premature ventricular obstruction, resulting in an apical to basal direction of flow. Note that this additional apical to basal flow during diastole doesn't make it out through the aortic valve because the aortic valve remains shut during diastole. Now we will dive into systolic anterior motion, or SAM. SAM refers to the anterior excursion of one or both leaflets of the mitral valve into the left ventricular outflow tract during systole, which narrows the outflow tract area and also causes a posteriorly directed mitral regurgitation jet. The hemodynamic impact of SAM depends on how long during the cardiac cycle the mitral valve leaflet remains touching the hypertrophied interventricular septum and how much area the contact is. How does SAM occur? SAM occurs from two principles in physics: the Venturi effect and drag. The Venturi effect describes the drop in pressure and acceleration in velocity when blood flows through a reduced cross-sectional area. If you imagine that a garden hose is a left ventricular outflow tract and your thumb is the bulging hypertrophy of the interventricular septum, you will notice the acceleration in the water flowing out of the LV outflow tract. The accelerated blood flow will pull along the mitral valve leaflet anteriorly, causing the mitral valve leaflet to get in the way of the LV outflow tract. Secondly, because the mitral valve leaflet is directly in the way of the LV outflow tract, the blood will attack the mitral valve leaflet at a larger angle alpha, dragging the mitral valve leaflet further anteriorly and preventing it from returning posteriorly to coact with the posterior mitral valve leaflet. This creates a prolonged opening that leads to a posteriorly directed MR jet. What causes SAM? The most common cause of SAM is HOCM. However, SAM can arise from any condition that reduces LV systolic cavity size. For example, from hypovolemia, tachycardia causing reduced diastolic filling time, or increased contractility. SAM can also arise from any condition that increases blood flow through the LVOT, for example, from increased contractility or reduced LV afterload. If SAM occurs in critically ill patients on pressors, you can switch from a vasopressor with mixed alpha-beta adrenergic effects, norepi-epidopa, to a pure alpha agonist, such as phenylephrine, to reduce cardiac contractility, heart rate, and LVOT velocity. What does SAM look like on 2D Doppler? Typical SAM. Most commonly, SAM is limited to the tips of the leaflets distal to the coaptation zone as the body of the leaflet bends. In this parasternal long axis view, only the leaflet tip has anterior motion towards a hypertrophied LV. Atypical SAM. Less commonly, the body of the leaflet also slides anteriorly because it does not bend. In this parasternal long axis view, the body of the leaflet doesn't bend and it moves together with the tip anteriorly. You can clearly see a posteriorly directed MR jet. What does SAM look like on M mode? After your E wave and A wave are done in diastole, during systole, instead of having a unified coaptation line that travels parallel to the posterior LV wall, you will instead have an anterior mitral leaflet that opens and makes contact with the interventricular septum and stays in contact with it for a while before coming back from the excursion. M mode can tell you if the timing of the SAM is early systolic, holosystolic, or late systolic. Next, we'll go over other imaging findings in HCM. Imaging to order in HCM at baseline, class 1 recommendation, echo, Holter, CMR, and exercise echo. Every 1 to 2 years, class 1 recommendation, echo, Holter, and exercise echo if the patient is symptomatic and LVOT obstruction is not proven yet. Every 3 to 5 years, the class 2B recommendation, cardiac MRI, and exercise echo if asymptomatic. LV aneurysm occurs in 5% of HCM patients. Compared to HCM patients without LV aneurysm, HCM patients with LV aneurysm are significantly 5 times more likely to have arrhythmias and 2 times more likely to have heart failure events or thromboembolic events, and slightly more likely to have HCM-related sudden cardiac death. A crypt is defined as a blood-filled invagination in the myocardium extending at least 50% toward the epicardium and end diastole. Crypts are usually located in the basal segments of the infraseptal or infralateral wall. There may be single or multiple in number. They should disappear during systole. Crypts have a high prevalence in genotype positive, phenotype negative individuals with HCM before they develop HCM, i.e., while their relative wall thickness is still under 0.42. However, crypts can also occur in patients without HCM, especially those with chronic hypertension. So you want to see if the individual has a family history of HCM or sudden cardiac death. Notably, crypts disappear when hypertrophy develops. A restrictive filling pattern is present in 2% of patients with HCM. If you're trying to measure the severity of valvular AS in a patient who has severe LVOT obstruction from HOCM, then the best way to do that is planimetry for aortic valve area by TEE. The continuity equation doesn't work because it assumes that the LVOT is circular and that LVOT flows uniform. However, in the setting of subaortic obstruction, these assumptions cannot be fulfilled. We'll wrap up by going over catheter findings of HOCM. When left heart catheterization is done with simultaneous measurement of LV and aortic pressure in both AS and HOCM, there will be a large gradient that exists between the LV and aortic pressure tracing. In AS, you have to withdraw the catheter across the aortic valve to the aorta in order for the pressure difference to disappear, whereas in HOCM, the pressure difference will disappear when you withdraw the catheter to the subaortic space in the LV outflow tract. In addition, in HOCM, the pressure tracing of the aorta and also the subaortic space, but not the LV midcavity, will show a bifid pulse contour with a notch on the upstroke called the spike and dome tracing. Also, pay attention to the LV end diastolic tracing. In HOCM, there is a notch at end diastole due to LV diastolic dysfunction from impaired LV compliance. What's the Brockenbrough-Braunwald-Morrow sign? It is a phenomenon in HOCM where after a PVC, meaning in the post-PVC beat, there is an increase in left ventricular pressure due to the compensatory pause, which allows for greater filling of the ventricle, but a paradoxical decrease in aortic pulse pressure because this increased contractility worsens the outflow tract obstruction, reducing the stroke volume ejected into the aorta. Normally, in the healthy heart, the post-PVC beat would be translated into an increased aortic pulse pressure, due to the increased filling and stronger contraction. The Brockenbrough-Braunwald-Morrow sign is highly indicative of dynamic LVOT obstruction, which is characteristic of HOCM. In differentiating HOCM and aortic stenosis, looking at the beat after the PVC is key. After a PVC, in HOCM, the gradient between the LV and AO is much wider, and the murmur is much, much louder, and the pulse pressure is decreased, as previously described. In aortic stenosis, the gradient between LV and AO is only a bit wider, and the murmur is only a bit louder, and the pulse pressure is increased. Whereas in MR, the gradient between LV and AO is unchanged, and the murmur sound is unchanged in the beat after the PVC. That's all for the epidemiology, physical exam, imaging findings, and catheter findings of HCM and HOCM. In the next episode, we'll talk about management.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.